takes that on themselves. They provide research and development, primarily through CDC and NIH, program implementation through USAID, and diplomacy through the Department of State and DoD. And it's really interesting. I had a couple of contracts with the DoD, the Division of HIV/AIDS Prevention Program, which is in the Navy, and they do military-to-military collaboration where they help the military determine the incidence and prevalence of HIV and then provide intervention plans for them. So the actors include USAID, the Department of State has PEPFAR under that umbrella, the DHHS has CDC, NIH, and FDA, and others. And then there's another set of organizations, the DoD, the USDA, and the Peace Corps. And the USDA, you wouldn't think that they would work internationally, but if you think about it, we import a lot of our food. If next time you buy a banana, look at the label on it. It probably comes from somewhere in Central or South America.
Looks like your presentation is flickering. There we go.
Okay. In 2011, the U.S. funding went to primarily Africa. The number of countries receiving funding that year were 36, and you can see from there on down the Western Hemisphere was 13 countries, all the way down to the Near East with 5 countries. Most of the funding that goes through global health, or goes to global health, is through the Global Health Initiative. They receive about 80% of the U.S. global health funding that they manage. So the top countries receiving U.S. funding in 2011, if you look, you have to get down to next to the last before you actually leave Africa. So the funding that's provided, from Kenya at 574 million, all the way down to Rwanda. U.S. is not alone in this, though. There are multilateral donors. The British have their equivalent of USAID. We have WHO, the Pan American Health Organization, the Global Fund to Fight AIDS, TB, Malaria, UNAIDS, and Gavi. There's a shift that's happening, and I mentioned this just a few minutes ago, in donor focus. One of the things that they're focusing on is an increase in activities with women and girls. They're disproportionately affected by diseases and by poverty in these countries. There's also an increase in health system strengthening, integrating services. So, for example, if a woman in Africa has to come to a village, if she's pregnant, she has to come to a village for her checkup, but yet her child that she has with her has to go to a different location for a vaccine. They're trying to bring all of that together. And again, the country ownership, they're trying to move from a donor-led to a country-led model. There's a couple of issues with that, though, because a lot of these countries are rife with corruption, and there's also a loss of donor control. So you kind of give that money over, but you don't really have a control in the way that the government implements the programs. So why should we invest in global health? Well, it saves lives. It creates jobs. We've talked about diseases not recognizing borders. It maintains a competitive edge for the U.S., and it protects our citizens and soldiers abroad. And these come from Research America, the top 10 reasons. It also supports U.S. research universities and student interest. There's an intersection between domestic R&D, driving medical discovery. It helps promote economic development, and it's a good investment that saves money, and they say a majority of Americans support global health. So how do we benefit from all of the money that we take to other countries and implement programs? Well, besides the humanitarian benefits and the lives saved, for every U.S. dollar spent on global health, 64 cents goes directly to domestic-based research and product developers. and generating jobs, etc. The NIH is the largest U.S. government health research organization, and Francis Collins, the head of that organization, says that for every U.S. dollar of NIH health research funding, which includes global health, it returns $2.21 in goods and services in a year. The U.S. contributed to 24 of 45 new global health products developed worldwide between 2000 and 2010. And these included a new effective TB diagnostic test, a meningitis vaccine, next generation HIV/AIDS therapies, and more beyond that. But still, remember that less than 1% of our funding goes to global health. So less than 1 cent out of every U.S. health dollar goes to global health. So let's take it from the government level, the U.S. government, and let's bring it down a little bit to the state level. How do states benefit from global health? Majority of state benefits come from NIH in the form of grants and contracts. That's where the states get most of their funding. California is the largest recipient of U.S. funding in global health. New York is another large recipient. There are also hubs of activity in Washington State and North Carolina. And also mentioned in this article were UT Southwest Medical Center up in Dallas. So here's a list of the largest funded states and the funding that they received in 2011. Again, California's at the top, and you'll see they go down to New Jersey, just the top few. So what does this global health funding produce? In 2010, there were 114,000 babies born without HIV as a result of the PEPFAR mother-to-child transmission programs. From 2004 to 2007, PEPFAR programs cut HIV/AIDS deaths by 10.5% in countries that they were targeting. In 2010, the IRS, indoor residual spraying, they provided spraying for 27.2 million people to prevent malaria. They treated nets for 17.5 million people. And this is through the President's Malaria Initiative. In 2007, treatment was provided for approximately 1.43 million TB patients. And from 1960 to 2009, we've reduced child mortality from 20 million to 9 million. That's some pretty staggering statistics. I left my other quote. I have a quote from Lindsey Graham, and I forgot to put it on here, but former Senator Bill Frist said, "Disease and poverty breed hopelessness, desperation, hatred, anger, and instability, all of which fuel the spread of radicalism." And if you want the Lindsey Graham quote, let me know, and I'll send it to you. So, the effect of this funding, and I just took these top three states. There are many states that have conducted studies of the impact of global health on their state. And if you'll look at these numbers, there's a little bit of a qualification behind all of them, so we're kind of not comparing apples to apples, we're comparing apples to oranges here a little, but I thought it was a nice way to show this. So, jobs supported, in California, they supported 62,000 jobs through NIH funding in 2010. And you can see in Washington it was a little over 13,000 and greater than 7,000 in North Carolina. Of course, the years are a little different. The average salary for an individual working in global health, in the for-profit sector in California, it was $71,500. In Washington, it was almost $56,000, and I did not have that figure for North Carolina. The percent or the dollar of annual taxes, California contributes 7% in 2007 to taxes for the state, and in Washington it was $143 million. The total amount of wages that global health provides in California is $19.7 billion, and in North Carolina it was $508 million. And then you can see the figures as well for the business activity that's generated. In California, it was $49.8 billion, but I also noted that it was greater than $7 billion for academia. So let's talk a little bit about North Carolina in greater detail. That's what I know about right now. As Ed mentioned, I work for RTI International. RTI was an organization that was formed back in 1958 by Duke, UNC, and NC State with the idea that they wanted an institution that could take and apply what was the research that was being conducted at each of these universities. In 2007, we had $216 million in grants. I think our revenue recently is over the $500 million mark these days. 51 million of that 216, though, was in global health. Academia, Duke, the Duke Global Health Institute was, and I get my years mixed up, but it was formed, Mike Merson came from Yale and formed that institute, I want to say 5, 6, 7 years ago. The UNC Chapel Hill School of Public Health, and they approximately have 90% of academia or that sector's funding in global health, those two organizations. There's also the for-profit pharma. There's Research Triangle Park is a very big pharmaceutical hub. GlaxoSmithKline, we have a lot of CROs as well, Quintiles, PPD, and they generate 3,000 jobs, 220 million in wages, and they export primarily to those countries listed there. So, let me tell you how the Triangle Global Health Consortium started. I don't know if you, so sports-wise, I'm not sure if you follow the ACC, probably not. But if you do, you know that Duke, UNC, and NC State are very competitive in basketball. And it's not just in sports that they're competitive, they're also very competitive when it comes to getting grants and contracts for global health work. So the idea that those three organizations could come to the table together is very unusual in a lot of ways. At the same time, RTI International, we compete with FHI 360, used to be FHI. They bought AED, and now they have a very large presence globally, as well as Futures Group and IntraHealth. So the idea that all of us could come to the table together was highly unusual, but we had great leaders that wanted to make this happen. So they planned an event one night in the back room of a restaurant, and they provided copious amounts of alcohol. And we sat down and talked about that we had in our own individual institutions, we had a lot of work in global health, and how could we ensure that, and I never remember this quote correctly, the whole is greater than the sum of the parts, that in other words, we have a nice hub of global health work in the Triangle, and how could we make funding organizations and others aware of that? So the idea was that we would form this consortium, the Triangle Global Health Consortium, and we did. Their mission is to establish North Carolina as an international center for research, training, education, advocacy, and business dedicated to improving the health of the world's communities. A mission shouldn't be that long, but you can imagine with all of those different players in the room, they all have to have their little piece put in there. So we engage academic, government, business, and nonprofit organizations in this effort. These are our members currently. You can see we have five universities, several nonprofit organizations, and a few for-profit organizations, the biggest being GlaxoSmithKline. This is our board of directors. I just thought I'd show their pictures for you. They're made up of folks from UNC, the North Carolina Biotechnology Center, Futures Group, IntraHealth, etc. Now, the goals and outcomes that we wanted to achieve in forming this organization was to brand North Carolina as a global leader. We wanted to serve the community of North Carolina because, as Dr. Robbins said, global health is local health. And we want to advance multidisciplinary and multi-sectorial communication, information sharing, and workforce development. Part of the idea is that individuals who go to school at those universities could do internships at some of the organizations that are members and eventually end up working there at some of them. In addition, we want to expand the global health sector in North Carolina. We're a little greedy. We want a little bit more money in that area. We want to expand the visibility and recognition, increase funding, and enhance recruitment of professionals and teachers and leaders. We want to enhance the global health education and training that exists in North Carolina, and I'll give you an example of that in a minute. Improve communication and information sharing, enhance innovation, and improve R&D outcomes. So, one of the things that I was talking to Dr. Robbins about was when you have an organization like ours, and our members pay dues, annual dues to join, you have to have some benefit for them. You have to have a value proposition that they buy into. And part of that is that one of the things that they're very quick to say is, what can you do for us that we can't do ourselves? I mean, GlaxoSmithKline's a gigantic company. And FHI, another big one in maternal and child health and HIV/AIDS, what can we help them do that they can't do themselves? And we struggle with this. As an organization, we struggle with identifying what it is that we could support and do for them. But we're working on it. So we have a list of memberships, and one of the ideas is a greater access to consortium members. We also try to form teams or collaborations to go after opportunities. So there were some CDC opportunities that, and it was really funny because FHI formed a team out of consortium members, RTI formed a team, and we both ended up winning because there were multiple awards. So we operate that way. There was also a USAID innovation opportunity last year, or maybe it was the end of 2011, and they were accepting concept papers, and the consortium submitted a concept paper. USAID received more than 470 concept papers, and they were only funding 7 awards for consortium. So we did not get asked back to develop a full proposal, but one of our members did, Duke, because they also submitted one on their own. So they get a prominent listing on our website with marketing privileges, including the logo. One of the logos that's not on our website, because they're still waiting for approval, is we did just recently recruit the research and development arm for the Clinton Health Access Initiative. As it turns out, the gentleman that is leading that organization, the research, he's the director, is based out of North Carolina. So we recruited him, and he's been a great asset. Participation in our programs, which include workshops, briefings, policy discussions, etc. One of the really successful programs that we conducted was one around the Gates challenges that are announced each year. We put together a program where there were several topics that people could sign up for, and they would come and you would sit at a table based on your topic, and you pitched your idea or your innovation, and you tried to get partners, or you tried to help others improve their idea. And we had somebody from USAID, from Gates Foundation actually speaking at that meeting. And it was a very successful one. It connected people in ways that they probably wouldn't have before. Let's see. We'll go through some of these benefits. As I mentioned, new funding opportunities, access to events at a reduced admission or free, booth registration at some of our events. I'll tell you about it in a few minutes. We have a annual case competition, a student case competition, and then job postings on our website. Let me tell you about a little bit of our activities. We have two very successful programs that we hold. One is our monthly breakfast discussions, and these happen the third Thursday of the month from 7:30 to 9 with a hard stop at 8:30 if people have to leave. And you would imagine that at 7:30 people probably aren't up, but they are. We have a very good turnout at these events. We have between, I'd say, 45 and 60 people at our breakfast meetings. Some of the discussions that we had this last year were Mike Cohen talking about prevention of HIV infection with early antiviral therapy. And for those of you who work in HIV, this was the HPTN 052 study that was highly successful, and they stopped it because it was so successful. I think it was with discordant couples. We had a discussion on cervical cancer prevention, and Engineering World Health talked about helping the world's poorest with healthcare technology. We had, one of the things that's happening is in North Carolina is hydraulic fracturing, or, also called fracking, where they go down deep into the earth and all the issues that it causes. So we coordinated with an environmental group in the Triangle and had a breakfast discussion, which was very successful. We had a lot of our legislators there. Improving water quality and modeling women-centered interventions. This is our global health case competition. Every year we develop a case, and students compete locally within their own university, and then they come together on a Saturday. So we release the case on a Monday, and they come together on a Saturday, and they compete in front of a panel of distinguished judges, and the idea being that they take this case and develop a solution for it. It's a real-world case that we try to, that usually one of our organizations will help develop the case, such that when a solution comes up, then the solution could potentially be implemented in the field. So, very successful. Our next case competition is on April 13th. We have an internship network. Some of our organizations provide internships to students. We do not match them up, but we do provide, when we do have interns at our organizations, we do provide a network to them. So they go to Durham Bulls games, they have social hours. They also, you'll see here, visit a lot of our organizations to understand what's going on. We had a nice article in the North Carolina Medical Journal several years ago on the impact of global health, and we've increased funding opportunities. This is that CDC opportunity that I mentioned to you, where we got 2 awards, and then the Gates grant. So we do better business in partnering, the monthly breakfast discussions, working groups. We have 3 or 4 working groups that have spun off from the consortium. There's a professional development and engagement group, and they work with the case competition. There's a gender working group and our One Health working group. And our One Health working group has actually spun off. It's a very successful group, with the idea being that you can't separate health from animals to humans. So I think I mentioned in my abstract that a chicken sneezes in Asia and we end up with a flu epidemic over here. The One Health, they have developed a course, a One Health course that is taught at all of the campuses. So all 3 of the major universities participate in this One Health course. We have a health system strengthening group, And then we've also coordinated with our members. There was a meeting called Shaping the Future of Global Health that FHI hosted, and we had folks there from CDC, from USAID, and from CSIS, the Center for Strategic and International Studies. Not going to go through this in great detail. We do have a career fair that happens at our case competition. This is where organizations will put a booth up and talk to students about what they're looking to do. The course internship network, and we also are starting to provide a catalog of non-degree education on our website. So that is my talk. I want to thank Ed, Michael, and Eric for having me here. I'd also encourage you all to talk about what types of opportunities you all can do with your collaborative. I think that there's a great deal of potential, especially with such a large, the largest, right, according to Wikipedia. But I think that you all should get together and maybe start forming some committees and talk about things that you can do. So we'd be happy to talk with you talk about some of our growing pains as you go along. So thank you.